Welcome everyone to the Alzheimer's Awareness Seminar of 2017. My name is Priya and I am the head of mental health department here at Lake Ridge Health. I just want to start off with introducing some background knowledge about this disease. So, Alzheimer's disease is a progressive neurological disease, a common form of dementia which can be very fatal. So some of the challenges that occurs with Alzheimer's patient is their cognitive and functional abilities, which includes individual will have difficulty keeping up with conversation, performing day-to-day tasks, and making decisions. Second, Alzheimer's affect emotion because patients become very moody, less expressive, and they basically lose interest in things they like or they're interested in, things like hobbies, social gatherings. Individual may constantly repeat the same actions over and over again. This would affect their behavior with others. Lastly, individuals cannot perform activities in their daily living, such as cooking, eating, showering, and keeping up with conversations. So today, we brought you numerous healthcare practitioners to provide you with further current information about Alzheimer's. During today's presentation, we will be discussing the risk factors and symptoms that characterize Alzheimer's, the epidemiology, the various rehabilitative strategies that are available to patients and their loved ones. First, I would like to introduce Kirthana Sukumaran, who is a representative from the Ministry of Health and Long-Term Care. Please join us in welcoming her.
Thank you, Priya. So I'm going to talk about how Alzheimer's is consistent with the definition of a chronic disease. So the Ministry of Health and Long-Term Care defines chronic disease using 5 main criteria. It is a long-term disease that develops slowly over time, often progressing in severity. It can often be controlled, but rarely cured. It may significantly impair everyday physical and mental functions, and it can reduce one's ability to perform activities of daily living. As mentioned before, Alzheimer's disease is a progressive brain disorder. It's known to be irreversible with deteriorating memory and thinking abilities. Alzheimer's can be characterized as a chronic disease as the diagnostics of the disease are consistent with the definition of chronic disease from the Ministry of Health Long-Term Care. It meets the first 2 criteria because Alzheimer's is primarily caused by cell death in the brain, and it starts off mild and progressively worsens over time. The disease slowly progresses in 3 main stages: mild or early stage, moderate or middle stage, and severe or late stage. After being diagnosed with Alzheimer's disease, patients can live up to 4 to 8 years on average, but depending on other factors, they can be expected to live as long as 20 years. And this shows how Alzheimer's disease does meet the first 2 criteria of the chronic disease definition, showing that it is consistent with the definition of chronic disease. The third criteria in the definition of chronic disease is that chronic disease can often be controlled, but rarely cured. Alzheimer's disease meets this criteria as it is an irreversible disease with symptoms that worsen over time. Although there is no cure for Alzheimer's disease, there are active services and programs to help improve the symptoms and quality of life for Alzheimer's patients. These include support groups, drug therapy, cognitive behavioral therapy, physical therapy, counseling, and services that aim to maintain mental function. The 4th and 5th criteria of the chronic disease definition states that chronic diseases may significantly impair everyday physical and mental functions and reduce one's ability to perform activities of daily living. Patients of Alzheimer's disease are often characterized or diagnosed based on their physical and cognitive impairment. So, for example, those that are in the later stage of Alzheimer's disease will require extensive and full-time care as they are unaware of their surroundings, experience difficulty communicating with others, and performing daily activities, and there will be changes in their memory, behavior, and their cognitive skills are going to worsen. So therefore, this all shows that Alzheimer's disease can be identified as a chronic disease as it is consistent and meets all 5 criteria of the Ministry of Health Long-Term Care definition of chronic disease.
Thank you, Kirthana. Now I would like to introduce Klapouszczak and Wagata Gribiasis, who are epidemiologists from Public Health Ontario.
Thank you, Priya. So, Alzheimer's is a long-term progressive neurological disorder in which the disorder most often progresses in stages, which can vary from person to person. As you can see from the slide, we'll be focusing on the mild and early stage. In that stage, the patient can still function independently and perform basic daily activities, such as driving, working, and socializing with others. These people require minimal assistance. Patients have mild impairment and may start to sense losses in memory. This includes forgetfulness, communication difficulties, mood, and behavioral alterations. The next stage is the moderate and middle stage. This is the longest stage and may last for years. Patients will require more extensive care. Patients now experience a greater decline in cognitive and functional abilities. This includes feeling moody. Patients may also experience personality and behavioral changes. This includes suspiciousness and delusions, repetitive behavior such as hand-wringing and tissue shredding. Final stage is the severe and late stage. This may progress into dementia. Patients will require full-time daily care and assistance. Difficulty to perform physical activities such as walking, sitting, and swallowing. Increased difficulty communicating pain and socializing with others. They are unaware of surroundings, and this can often lead to death.
So there are many risk factors that contribute to the development of Alzheimer's disease. So this image shows the difference between genetic factors and non-genetic factors. So the first ones we're going to be paying attention is to genetic risk factors, and these are non-modifiable risk factors. So they include age, which is the strongest risk factor known, because as an individual gets older, they have a higher chance of developing Alzheimer's. Gender is also important because women are more likely to get the disease more often than men. And then family history, because individuals with parents or siblings with Alzheimer's have a higher risk of acquiring the disease themselves. So if we look at the other portion of the image, we're going to be paying attention to the non-genetic risk factors, and these are modifiable risk factors. So these are risk factors that you can actually change. So high cholesterol levels in the blood, high blood pressure, diabetes, smoking, and obesity all lead to a higher risk of developing Alzheimer's disease. So the occurrence of Alzheimer's disease is shown in this image, and it was taken from the World Health Rankings. So the prevalence rate of Alzheimer's disease rises exponentially with age, especially after 65 years old. Compared with Africa, Asia, Europe, the prevalence of AD, Alzheimer's disease, appears to be much higher in Canada, which may relate to the methods of prolonging life. The red regions on the graph indicate, like Canada, with higher prevalence of individuals living with Alzheimer's disease. So this can be compared to the purple regions, such as sub-Saharan countries, which have lower prevalence of people with AD due to the scarcity of medical advancements in those regions.
Thank you, Wagata and Salik. Up next, we have Dr. Janea John and Dr. Marcus Hudson, who will be describing the characteristic of Alzheimer's disease.
Thank you, Priya. There are 10 warning signs and symptoms for Alzheimer's disease. The disease affects each individual differently. The symptoms, the order in which they appear, and the duration of each stage vary from person to person. In most cases, the disease progresses slowly, and the symptoms of each stage may overlap, often making the move from one stage to another quite subtle. If you notice any of the following signs, please see a doctor. 1. Memory loss affecting day-to-day abilities. One of the most common signs of Alzheimer's disease is memory loss, especially struggling to retain new information. Others include asking for the same information over and over, and increasingly needing to rely on family members for things they used to handle on their own. 2. Difficulty performing familiar tasks. People with Alzheimer's often forget how to do things they've been doing their whole life, such as driving to a familiar place, preparing a meal, or even getting dressed. 3. Problems with language. Individuals may have trouble following or joining a conversation, struggle with vocabulary, have problems finding the right word, or repeat themselves. 4. Disorientation in time and space. People with Alzheimer's often lose track of dates, seasons, and the passage of time. They can also get lost in a familiar place and forget how they got there. 5. Impaired judgment. People with Alzheimer's may experience changes in judgment or decision-making. This includes not recognizing a medical problem that needs attention or wearing light clothing on a cold day. Typical age-related changes are often misinterpreted as signs or symptoms of Alzheimer's disease.
Typical age-related changes are defined as developing very specific ways of doing things and becoming irritable when a routine is disrupted. For instance, someone with Alzheimer's may lose track of the date or season, whereas a person experiencing age-related changes may forget which day it is, but remember it later. Some other common misconceptions are listed in the table developed by the Alzheimer's Association. There are several myths and misconceptions about Alzheimer's disease and what it is, who gets it, and how it affects people. Myth 1. If I am diagnosed with Alzheimer's disease, it means my life is over. Eating a heart-healthy diet, exercising regularly, staying socially connected, and doing things that challenge your brain can also slow disease progression. Myth 2. My mother had Alzheimer's, so I'm going to get it too. The genetic inheritance of Alzheimer's disease accounts for less than 5% of all cases. Myth 3. Alzheimer's is a disease of the elderly. Alzheimer's disease is a progressive degenerative disease of the brain. It often occurs in people over 65, but can affect people in their 40s and 50s.
Psychosocial, environmental, and lifestyle factors have a heavy influence on the complexity of Alzheimer's disease. The individual with this mental disorder has several symptoms that prevent them from interacting with people in their day-to-day lives. Simple things such as memory loss and language difficulties prevent them from being able to share their ideas, opinions, and feelings with others, thus affecting their ability to communicate with healthcare professionals, friends, and/or family members who are trying to assist them. Changes in mood, behavior, and personality may also make it difficult for them to interact with others in a social aspect, making the development of new relationships very challenging. The common symptoms such as misplacing important things and impaired judgment of recognizing medical problems can also put them at risk for being physically harmed by their surroundings. Unintentional self-harm often happens within the home environment, as there are many hazards such as falls near stairs and objects in kitchens that may cause bodily harm. This inability to do simple daily functions without constant assistance hinders an individual's quality of life, and they are eventually unable to pursue their ideal lifestyle. The complexity of this disease increases a patient's healthcare utilization, thus making this disease even more complex. Alzheimer's patients may require a variety of healthcare services to help manage their disease. Therefore, a significant amount of money goes into the care of these individuals. In addition, a lot of money goes into the research of Alzheimer's disease and how to manage and care for the people who are diagnosed with it.
Thanks, doctors, for the informative presentation. I know many of you have been eager to learn more about the rehabilitative strategies, so Zara Kamli will be speaking next. She is a physiotherapist who will be sharing interventions and programs that may be beneficial.
Thank you, Priya. Now I'm going to be moving on to rehabilitation programs and strategies. And so since the signs and outcomes of Alzheimer's disease is so vast, there are many rehabilitative strategies to improve and maintain quality of life. Rehabilitation programs differ depending on symptoms, expression, and outcome of disease, and these variables determine the amount and type of assistance needed. Services such as physical therapy, occupational therapy, cognitive rehabilitation, and speech pathology services can be very beneficial throughout various stages of AD. In the early stages, functionality is key. Physical therapy improves balance, muscle strength, and mobility. It will provide pain management and prevent falls from occurring. People are at a greater risk of falls and mobility problems due to muscle weakness, gait, balance deficiency, and cognitive impairment. Physical activity such as exercise maintains strength and thus will help to maintain quality of life. Environmental modifications such as adding labels and signs to the home may allow a person to become as functional as possible. In the middle to late stages of Alzheimer's, there are increasing challenges in performing activities of daily living. Occupational therapists help to manage these daily tasks safely and with minimal stress and anxiety. Occupational therapists will assess a patient's ability to walk, their risk of falls, and other functional tasks. They will develop a treatment program, including exercise, to maintain current abilities, relieve caregiver burden. It is important to keep in mind that daily skills lost may not be regained. Physical exercise, social activity, proper nutrition, and health maintenance is important in managing the disease. Occupational therapists will plan daily activities that provide structure, meaning, and a sense of accomplishment for the patient. They will adapt activities and routines in order to allow the patient to participate as much as possible, as function may progressively be lost. Palliative care may also be necessary in the late stages of Alzheimer's. Cognitive training and rehabilitation is a non-pharmacological method commonly used with patients to help make the most of their memory and cognitive function. Cognitive training focuses on guided practice and tasks that reflect particular cognitive function, such as memory, attention, and problem-solving skills. Cognitive rehabilitation focuses on addressing individual needs and goals, making it patient-centered. Patients may require strategies for taking in new information, compensatory methods, such as using memory aids. It is important to plan activities of daily living and self-efficacy as well.
Thanks, Zara. I'd like to call upon Darsiga Devikumar, a research coordinator who facilitated an Alzheimer rehabilitative study.
Thanks, Priya. So I volunteered for a study done by the following authors listed on the screen. They conducted an RCT that ran for 12 months that took in nursing home residents with mild to severe Alzheimer's in France. So the purpose of this study was to investigate the effectiveness of exercise programs in improving ability to perform activities of daily living, physical performance, nutritional status, and decreasing behavioral disturbance and depressions in patients with Alzheimer's. Consent was obtained from patients and caregivers or legal guardians. So subjects were randomly allocated to either the intervention or the control. The intervention being the exercise group and the control group being a routine medical care. A single geriatrician was blinded to the intervention assignment and measured outcomes at baseline, 6 months, and 12 months on different days of the intervention. The study had clear inclusion and exclusion criteria for study participants, which is on the slide, and it took a total of 429 nursing home residents, and only 242 residents met the criteria, and 134 residents are the only ones who gave consent and were included in the final study. Each session consisted of 2 to 7 subjects selected according to their baseline physical performance scores, their MMSE scores, and behavioral disturbance and affinity between participants. The exercises were first given at light intensity and was gradually increased according to the patient. So that means that each exercise was individualized based on their readiness. And each exercise lasted around 1 hour, which was done twice a week, separated by at least 2 days. The control group, on the other hand, all they received was routine medical care. The RCT lasted 12 months, and after it was finalized, there was no differences in baseline characteristics between the intervention and control. At 6 and 12 months, activities of daily living decreased in both groups, and mean walking speed increased in subjects part of the exercise program. No effect was observed for behavioral disturbance, depression, or nutritional assessment scores. The PEDRO scale was developed by physiotherapists in Australia and provided an outline in order to determine the internal validity, meaning whether the research is of good quality or not. So we've applied the PEDRO criteria for the research study, which will be shown on the next slide. So the PEDRO scale has 11 criteria. The criteria met include criteria 1, which is when the exclusion and inclusion was clearly stated, which influences external validity. Criteria 2 is when subjects were randomly allocated, which was through lottery draw. Criteria 4, which is at least one measure of the severity and key outcome was done throughout the study. Criteria 7, which is blinding of a geriatrician who assessed at baseline 6 months and 12 months. Criteria 9, all subjects receiving the treatment that they were supposed to receive. And when this was not the case, intention to treat was used. And criteria 10, stats comparisons were used between the intervention and control. So the criteria that were not met include criteria 5, which means that the subjects knew which group they were allocated to. So they knew that if they were in the intervention or if they were in the control. Criteria 6 is that the healthcare providers were not blinded for the intervention as well. Criteria 8 is that key outcomes were measured only in about 82% of the total study sample, which it should be over 85%. And criteria 11 is that point measure was not measured. However, measures of variability were found.
Thank you, Darsiga. We want to thank everyone for attending the Alzheimer's Awareness Seminar. We hope you found the information today helpful. and that you make use of many Alzheimer's rehabilitative program offered at Lake Ridge. We also offer other seminars to provide caregivers the knowledge they need to create a supportive environment at home. Our aim is to ensure that all Alzheimer's patients achieve their optimal level of function through these rehabilitative programs, ultimately improving the quality of life. Thank you.